Exploring the Vasculitis Phenomenon. Primary authors Dr. Sasikant Ravi, co-authors Dr. Christopher Liu. Mentors include Dr. Mohammed Jamil and Dr. Georgiana Georgescu. Clinical history includes a 57-year-old woman who was admitted for generalized weakness, 30 to 40 pound unintended weight loss, pancytopenia, worsening renal injury, and development of multiple purpuric rashes on bilateral lower extremities over the duration of several months. We pursued a comprehensive rheumatological workup, which was largely unremarkable for rheumatoid factor, protein electrophoresis, HIV, Sjogren's, double-stranded DNA, and anti-Smith antibody. While we were doing this workup, the patient had developed a fever for which blood cultures grew gram-positive cocci bacillus, which was later identified to be Abiotrophia defectiva. An echocardiogram showed severe mitral regurgitation with a mobile echo density on the anterior leaflet with severe prolapse. While we were doing the cardiac imaging, her pancytopenia was also evaluated with a bone marrow biopsy, which was largely benign, and renal biopsy was then performed and demonstrated glomerulonephritis with focal necrosis in 2 out of the 16 glomeruli. And initially, it was thought to be quasi-immune glomerulonephritis. The clinical picture was most suggestive of post-infectious GN, with a negative ANCA, MPO, and PR3 and low complement. She was preoperatively stabilized in the ICU through dialysis, IV vancomycin, bilateral thoracentesis, and GCSF administration. She eventually underwent a mitral valve replacement with ligation of the left atrial appendage, and a few days after the procedure, Coumadin was introduced, and she was discharged to a rehab center with IV vancomycin. Before we get into the immunology and pathology portion, it would be fundamental to understand what exactly is infective endocarditis. Infective endocarditis is the infection of the endocardial surface of the heart, primarily attributed to the Viridin group Streptococci and Staphylococcus species. Infective endocarditis can encompass a plethora of other microorganisms as well. One such organism includes a nutritionally variant Streptococcus, namely Abiotrophia defectiva. In a retrospective analysis, it was demonstrated that NVSIE is associated with higher rates of complications including antibiotic failure, infection relapse, septic embolization, and increased mortality compared to infectious endocarditis caused by all other Streptococcus species. The purpose of this poster is to highlight the challenges associated with diagnosing NSV endocarditis in the presence of an atypical clinical presentation. In Figure A, you can see an aerobic blood culture showing slight elongated gram-positive cocci, and in Figure B, you can see basically the colony growth of Abiotrophia defectiva in a chocolate agar, and then C, you can see the satellite growth of the same organism in proximity to a hemolytic staphylococcal streak. The important thing about this presentation was that our patient had a cutaneous vasculitis presentation, the purpuric rash. The diagnostic challenges associated with these kind of vasculitis is there is an extensive list of differentials that includes for vasculitis syndromes. The widespread differentials have to be targeted in a systematic way based on clinical, pathological, and immunological features. One such classification is discussed down below and divided into 4 subdivisions: necrotizing vasculitis, hypersensitivity vasculitis, granulomatous vasculitis, and other vascular syndromes which include Kawasaki disease and thromboangiitis obliterans. For our specific case, it would be more classified under hypersensitivity vasculitis due to the Hinanch purpura and vasculitis associated with infection, malignancy, or connective tissue disease. Anti-neutrophil cytoplasmic antibodies, ANCAs, directed against proteinase 3, PR3, or myeloperoxidase, MPO, are key diagnostic markers for ANCA-associated vasculitides, AAV. These vasculitides are predominantly affect the small vessels and form a group of disorders that include the granulomatous with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. They all share a similar feature on renal histology in the form of focal necrotizing, often crescenteric quasi-immune glomerulonephritis. This case hopes to illustrate how infectious disease, particularly endocarditis, have been reported to exhibit positive ANCA and mimic these vasculitides. The imitation of these clinical features is also demonstrated to the same extent in ANCA negative endocarditis as well, which pertains to our patient. The lack of specificity in these clinical manifestations can lead to misdiagnosis and inappropriate initiation of immunosuppressive therapy, which can worsen the underlying infection. The lack of consistent clinical features and the possibility of a misdiagnosis necessitates a comprehensive workup with immunological and pathological components. Down below in these A and B slides, we are hoping to demonstrate granulomatous with polyangiitis and ANCA-negative quasi-immune glomerulonephritis. As you can see, they both have cellular crescents, but the most important differentiating factors would be the key diagnostic markers of ANCA, PR3, MPO, and then examining these tissue or example slides under immunofluorescence and electron microscopy. Lastly, the diagnostic approach in order to establish a diagnosis of endocarditis is one of the most important steps before we can approach a treatment. The highly variable clinical presentations of endocarditis can be attributed to the plethora of organisms and the chronicity of the disease itself. It can be classified as acute, subacute, or chronic condition. In conjunction with the nonspecific symptoms, with up to 90% of the patients presenting with fevers, night sweats, fatigue, appetite, and weight loss, it can create an understandable diagnostic challenge. The modified Duke criteria are used in the evidence of clinical suspicion to help with this diagnosis of endocarditis. It is shown to be an invaluable tool with an overall sensitivity of 80%. One of the most important steps when you have a high clinical suspicion for endocarditis is to obtain a blood culture. These modern blood cultures contain sufficient nutrition supplementation to support the growth of most cultivatable causes of endocarditis, which includes the Hayseck organisms and nutritionally variant Streptococcus. Therefore, it is important to recognize that culture-negative endocarditis are primarily due to the administration of antibiotics prior to obtaining the culture. The American Heart Association actually recommends at least 3 sets of blood cultures collected within at least 1 hour between the first and last draw allow for a successful detection of bacteremia in up to 98% of the cases. In the absence of prior antibiotic exposure and high clinical suspicion of endocarditis, and with a prolonged incubation time, serological testing should then be pursued for culture-negative endocarditis, for example, Bartonella, Coxiella, and Aspergillus fungal species. In patients indicated for a valvular surgery, the PCR analysis of the valve tissue can be done, which can identify the microorganism in most cases. If all microbiology testing is negative, then non-bacterial thrombotic endocarditis, SLE, Liebman-Sachs endocarditis, trauma, and hypercoagulable states have to be excluded through comprehensive investigation. On the top right-hand side corner, you can see the radiological imaging, and what that arrow tries to highlight is the septic vegetation that's shown on the echocardiogram imaging. Is a nutritionally variant Streptococcus that's prevalent in 4 to 6% of Streptococcus infectious endocarditis. It's extremely aggressive in its nature and can lead to a higher rate of complications similar to other NSVs. ABI is part of the local human flora and native to the oral cavity, urogenital, and intestinal tracts. However, immunosuppression, prosthetic valves, and predisposing factors like pregnancy can lead to the infectious state. Our case is unique in that our patient had no identifiable predisposing factors, but upon initial presentation was thought to have hematological associated vasculitis with cutaneous manifestations. When we first saw this patient, the progressively deteriorating renal function and the cutaneous vasculitis with an initial positive ANA and hypocomplementemia, low C3 and C4 levels, led to an initial differential of lupus nephritis. While undergoing workup, as discussed previously, blood cultures grew abiotrophia defectiva, echocardiogram showed a vegetation. While this supported the evidence of endocarditis, it was inconclusive in differentiating between infectious and Liebman-Sachs endocarditis. In order to further differentiate the diagnosis, a renal biopsy was performed, but that showed evidence of quasi-immune glomerulonephritis with focal crescents. This histological finding is also nonspecific and was similar in both lupus nephritis and post-infectious glomerulonephritis. In parallel, a comprehensive immunological workup revealed negative ANA, anti-SSA, DS, double-stranded DNA, anti-Smith antibody, ANCA, MPO, PR3. This comprehensive immunological workup allowed for us to clearly define a diagnosis of bacterial endocarditis in accordance with the modified Duke's criteria of 1 major and 3 minor criteria. Despite the complexity and the variation of the clinical manifestations of endocarditis, this poster hopes to emphasize the importance of a systematic approach through possible differentials in order to allow for early detection and appropriate treatment of NSV.